सर उनका ना टॉक चल रहा है वहां पे चेन्नई में।
अच्छा।
सो दे थॉट कि वो खत्म हो जाएगा, खत्म नहीं हुआ वो। सो नाइन
कोई
फिफ्टी
प्रॉब्लम नहीं
खत्म
है, हम
होगा।
शुरू करते हैं। आप ही तो स्पीकर हो ना।
हाँ जी, हाँ जी, हाँ जी।
चलो, गुड मॉर्निंग respected faculty and dear delegates. Welcome to today's session of e-PICU online master classes. I welcome Dr. Pankaj Garg and congratulate him, and also Dr. Mukesh Thankar for being elected as EP member for Central IP from Delhi again. Over to Dr. Pankaj Garg.
Good morning, dear faculties, dear friends. So I'm speaking to you after some time because I was recused because of the election process. I have been attending the e-master class of pediatric intensive care course, and it's been an excellent course which is being done by IIP Delhi, and I congratulate Dr. Maninder Singh Dhaliwal for excellent program and its meticulous execution. He has been there in all the sessions, and all the questions answered which are being discussed after that is actually very, very nice. So I've been in an academic institution like Gangaram. Still, I feel that these institutions do provide a lot of education, but these courses give you a more broader perspective of whatever is happening in that field. So it's excellent opportunity for everybody to learn about all these issues. And today we have a great session by Dr. Maninder himself on trauma care. And I welcome Dr. Anand for being the chairperson of these sessions, and Dr. Sham Meena, the secretary of IP Delhi, is also joined. So welcome all. Thank you so much for being there for me also during these elections process. And now we are back to our academic basics. So, welcoming all, I request Dr. Sham Meena to say a few words, and then we'll hand it over to Dr. Maninder. Dr. Sham, sir.
Hello, good morning to all. On behalf of Indian Academy of Pediatric, very warm welcome to all our chairpersons, delegates, as well as our speakers. And thanks to all to join this scientific activity. Over to Dr. Maninder.
Hi, hi, hi.
Dr.
Good morning.
Ajay is available.
I already spoken. I request Dr. Maninder to introduce the chairperson and then start the session.
Perfect. So, thank you, everyone. A very good morning to everybody. So, I would like to introduce Dr. Anand Bhutra. He is the director of ERA Mother and Child Hospital in Nagpur. He has been actively involved in intensive care from way back in 2010. He had worked in bigger and private institutes and has great bedside practical knowledge. Welcome, Dr. Anand. And Dr. Rajendra sir is right now in another conference. He'll be joining in 15 minutes. So he's taking a talk somewhere. It got delayed. So with that, let us move to the topic, pediatric polytrauma. This is like the modern neglected disease. People talk about pneumonia, people talk about diarrhea, dehydration, but nobody's actually talking about a very important disease, that is polytrauma or trauma, because they are mostly unwilling or maybe unprepared, and it's taken over by pediatric surgeons, sometimes neurosurgeon. So therefore, people are not exposed to it. But important thing is we should not be unaware. So with that, let me begin my very simple question and answer. If a kid with serious injury comes to a clinic, can I refer him straight, or is it must for me to attend that case? So the answer, I'll give it very simple, clean. Yes, you have to attend that patient. However, OPD patients might be waiting. You have to attend to that patient because it's a matter of life and death. And you have to sometimes accompany the patient to the hospital also if needed. I don't have anything in my clinic to help a trauma kid. So it's now essential that you start keeping the basic CPR material also. And if you do not have, then it becomes more essential for you to accompany the child. Sending the child in auto is not right. Calling an ambulance is also an acceptable thing, but you have to attend to that child. So with that, let us do a structured evaluation. Whenever a kid comes, you have to do an initial impression called the PAT assessment as per PALS protocol. You follow the primary assessment, the ABCD pentagon triangle. Then you go for the secondary assessment, and then you go for your diagnostic tests. So this is how you should follow this. You should have a pad triangle which says the appearance, breathing, and color, and then use the primary assessment, that is airway, breathing, circulation, disability, and exposure. Whenever you are dealing with a polytrauma or any emergency, you have to go a structured approach. If you do not follow, you are bound to miss something. And that miss can be as simple as a blood sugar or as late as a unequal pupils. So make sure you go through this approach and classify the patient, whether the patient is having a respiratory distress or a failure, compensated shock or hypotensive shock, or it's a cortical or brainstem phenomena. You broadly classify. We are not over here for etiological classification. Broadly classify at what level of stage he is in. If you can see, many number of diseases are actually falling down in their incidence because of vaccination, because of improved healthcare, preventive care. But injuries, they have remained static over the years because they are mostly accidents which are unplanned for. So whenever a trauma happens, you have to know what is the definition of polytrauma, what is the primary survey, how many teams are involved. You should know about damage control. You should know about inflammation and coagulation. We'll briefly go through them and then we go towards TBI. So polytrauma does not mean multiple fractures. Multiple fracture is a purely orthopedic problem. But polytrauma is a multi-system injury when there are two systems involved or one major system involved and the other is minor. So there are many number of definitions you can come to with different number of books. But to keep it simple, two major system injury, one major limb injury, one major system injury with two major limb injury, one major system injury with open great skeletal injury, unstable pelvic fracture itself a polytrauma. So why this is important? Because your escalation matrix, treatment matrix will be very much important. So whenever a small abrasion also happens when you fall down, there is intense pain, there is intense inflammation. Imagine when a polytrauma happens, how the body will react. It will be in a heightened state of inflammation with tachycardia, tachypnea, fever, redness, swelling, everything happening at the same time. And the more severe the trauma, bigger the inflammation, bigger the body's response. So whenever a first hit happens, you get a first injury either to the head or to the pelvis in a case of children because of bike injury or an accident or a fall from height. This is a purely mechanical insult. You get injured, there's a fracture that happens, that's a mechanical insult. The injury can be towards the chest, abdomen, or extremity. This is called as the primary injury. Then the secondary hit takes place or secondary injury when the body reacts to it, release inflammatory mediators. And if you do not appropriate support it, then the patient will go into hypovolemia, hypotension, hypoxemia, acidosis, and the whole body will be in reaction. So here is what we want to prevent. We want to prevent the secondary injury that is taking place by correcting hypovolemia, hypotension, hypoglycemia, hyponatremia, hypoxemia. This is important. Primary, we cannot treat, but the secondary is very important because if you prevent this or treat this, you will be able to save a life. So immediately after an injury, there is a peak of deaths, which is due to mechanical insult. But the second peak of death happens in the first 1 hour, which is totally preventable if we give adequate volume, oxygen, and supportive care. And the third peak of death happens in the second or third week when the patient gets a secondary sepsis and then he dies. So we have to be careful that our interventions which are done in the first 1 hour or thereafter should not lead on to sepsis and MODS. So this is how the pattern of injury and deaths looks like. So we should be careful in our management. We should definitely work on the golden hour and focus on the third peak of deaths. So this is what the golden hour means, that whatever you might do, you in the first 1 hour, if you are doing the right thing, then you will save the life. Otherwise, in the first 1 hour, if you have not done the right thing, the patient will die maybe 3 days or 2 weeks later. So the first 1 hour treatment is the golden hour to prevent his death, which might occur after 2 days or after 2 weeks. And this was given at a time when there was no scientific evidence to support this statement. This was just out of experience that this statement was given, and the golden hour became famous after that, and it is now well proven. So 50% of the mortality occurs before the patient reaches the hospital because of inadequate manpower or people who are unaware what to do about cervical injuries, the general public. But 30% occur within first 4 hours of reaching hospital, which is totally preventable, and 20% occur within the next 3 weeks, which is because the golden hour was not taken into consideration. So the treatment is very, very simple. You have to save a life first, then you have to save a limb, and then, if possible, save the whole body and the physiological functions. So once you are managing a polytrauma, saving life is important. Then comes saving the limb. And then comes saving the whole body and physiological status. And the team managing this has to be multiple. It's not a one-man job. You need a team which consists of an intensivist, a surgeon, a neurosurgeon, orthopedic surgeon, nurses, and technician. And every team must have a team leader, because in chaos, nothing will work well. So this is how you should place yourself around the patient. The airway is taken care by the pediatrician. The nurse stands on one side with the monitoring and defib, the chest compression on the other side. The third nurse will take care of medication. One is a recorder telling how much time has passed. And the team leader can be a physician or a trauma surgeon or a neurosurgeon. And the parents need to be spoken to by another counselor. So this is how you should arrange your team. A team of minimum 6, maximum 10 are important to manage a case of polytrauma. And because the head is relatively big in a child, so therefore head injuries are very common in children. And it's very important we know that our anatomy of a child is very much different, with a big occiput, smaller airway, anteriorly placed airway, and a narrow airway. So things become very, very tricky when we are dealing with children. I'll discuss this in the TBI section. So many of the times, parents will come and they will demand a CT after a fall from bed, or you will be scared that if I don't do a CT, will it cause, and the child has something later on. So this is a pecan rule that everybody should be aware of. If a child is younger than 2 years and is having altered mental status, is having a GCS which is less than 15 and a palpable skull fracture, you will definitely go for a CT. In child 2 years or older with altered mental status, GCS of even 14, and the sign of basilar skull fracture, you will go for a CT. Then, if the child has a period of loss of consciousness of more than 5 seconds, or has a parietal occipital trauma and is not acting normally, or the mechanism which is more than 3 feet in the case of younger than 2 years, you can wait in the emergency for 6 hours and decide whether to do CT depending in the period of 6 hours where you think the child is improving or worsening. Whereas if none of them are there, that means there's no loss of consciousness, no hematoma in the parietal occipital area, child is acting normally, just irritable because of pain, then no CT is required. So stick this pecan in your OPDs and your emergency so that you are very clear what to do. This is evidence proven. 99% it is very, very sensitive. So do not worry, nothing will happen if you do not do a CT scan. Then cervical spine injury again is very uncommon, but you do not want to do it in a conscious patient, in a cooperative patient who says that he's walking and very much normal. But if a child is unconscious, is having a focal deficit, is having a midline tenderness, and you feel it was the child was thrown out of the car, then you have to protect the spine. Otherwise, in a child who came in walking, talking with no pain in the back, then no need to protect the spine. It's important you should know where to protect the spine. So how to immobilize? These are cervical collars. The hole that you see in the collar in the front is for tracheostomy, and it also shows that it should be in the front of the neck, not behind. This is just an example. The back support will never have a hole. So this is how your cervical collars are being placed. They are there in every ambulance. People are not aware of it, and they come in different sizes. They are even adjustable ones. So today, go to your ER or to your ambulance and demand for a cervical collar. They are mandatory to be kept in police ambulance vans also. Then comes how to stabilize the head with hands. Suppose you have put a cervical collar and you don't have it, then you can place your hands onto the shoulder and put the head like this between the arms so that the child does not do a left to right movement. So this prevents the left to right movement. Cervical collar prevents the left to right and also a yes and no movement. So yes and no movement will be a little bit difficult when you place arms side to side. So sometimes you have to place a band over the forehead by using the gauze pieces or by using a tourniquet. And then because it is cervical spine, you only have to do a jaw thrust in these kids. Jaw thrust are being done by placing the thumb over the cheekbone as a pivot and then lifting the jaw forward and upwards by placing the fingers below the angle of mandible. This is how you do a jaw thrust in both the sides of the patient. Make sure when you are doing this, do not head tilt. Head tilt is contraindication in case of cervical spine injury patients. But in case there is you're not able to do jaw thrust, then and the patient is gasping, then you can go for head tilt because saving life is more important than saving the limbs. This pediatric assessment triangle, I think so everybody knows. You should know the appearance, work of breathing, and circulation. The essentials in primary survey, you ask this question, what is killing the patient? And then you treat it by resuscitation. Then secondary survey is done to identify other injuries so that you plan a definite care that what to do. So primary survey in polytrauma is basically focused on saving a life by giving appropriate resuscitation from head to toe. Whereas secondary survey is once you identify and stabilize the patient, you look for other injuries and develop a definitive plan. So this is what the primary survey looks like. Airway over here comes with cervical spine control, breathing, circulation. You have to control the external bleeding and give fluids, dysfunction of CNS, and at the same time, you have to look for dextrose and expose the patient so that you know there are no internal injuries, and at the same time, prevent hypothermia. These patients are prone for hypothermia. And if you do not know the GCS, then look for AVPU score, and the patient is not responding to just responding to pain, has a GCS of 8. Not responding means it is less than 8. Less than 8 means you have to basically consider intubation. So protection of spine is very much essential. Assume a cervical spine injury in any patient with multi-system trauma, especially with an altered level of consciousness or a blunt injury above clavicle. This is the simple rule that you should follow. And intubation in such patients, somebody has to stabilize the neck, make sure the neck will not be flexed or extended, and then one person intubate from the other side. So it's a 3-person job to intubate a patient with suspected cervical injury. Also remember, if you have a Broslow tape, it is available in the market, not expensive. You can then easily calculate the ET size. Preferably is to use a curved endotracheal tube to prevent aspirations because there will be much bleeding which might be happening in the oral cavity too. In small children or infants, you prefer the straight blade, and in bigger children, you prefer a curved blade technique. Straight blade, you lift the epiglottis also. Curved blade, you put in the vallecula and then lift the epiglottis. So the difference between the infant and children intubation techniques. Whenever a case comes with polytrauma, there's a lot of chaos. The first step is to be calm yourself, take things under control, reassure the parents and work on the child, and take universal precautions, and always keep medico-legal documentation in your mind because it's a medico-legal case. Don't be distracted by this blood and the screams. And definitely if the child is not crying, that means the brain is affected and it should definitely scare you. Shock is definitely missed most of the times because children can compensate shock better by giving tachycardia and peripheral vasoconstriction. But we have to recognize this shock. Just a normal blood pressure should not be a focus point. We have to look at the CRT, look at the peripheral pulses, look at the temperature, and then decide on fluids, because once a trauma happens, you have to replace blood with fluids initially and then with blood itself. And this should be done in the platinum half hour in the trauma resuscitation. You have to give lots and lots of fluids. Crystalloids, normal saline, colloids are not recommended. So decomposition can occur rapidly, and once decomposition happens, the reserves are gone and the whole system will collapse. So it's very important you recognize the patient before decomposition in children. So you define hypotension by using systolic blood pressure for a neonate less than 60, infant less than 70, and a systolic blood pressure of less than 90 in child greater than 10 years, provided you use the correct cuff size. Immediately apply pressure to the external bleeding that you are able to see. Apply the large bore cannulas, give 20 cc normal saline bolus or plasma light bolus, and do a e-fast. And after first bolus, if the child continues to be hypotensive, start a PRBC. This is the latest recommendation. Earlier, we used to give 2 or 3 boluses before we give 10 cc per kg PRBC. Now they are saying earlier the better, and you don't need to see a hemoglobin to decide your PRBC. You look at the color, you look at the BP, you look at the blood loss, and you give. Do not wait for documentation of hemoglobin. Because traumatic shock is 60% hypovolemic, 10% it is obstructive, maybe cardiac tamponade or maybe a pneumothorax. Distributive is only 7% and cardiogenic is 3%. So it's mostly hemorrhagic until proven otherwise. So therefore, give blood. Do not be scared of giving blood. And then you see the response to the treatment, the blood pressure, the skin perfusion, the consciousness, out of which the 3 end organs that you should look for is a urine output, the CRT, and the consciousness of the patient. If all 3 are okay, you are fine. But if they are not fine, you have to keep on evaluating again and again, because now they might be fine. After 15 minutes, they might suddenly bleed. There might be a hidden abdominal trauma where the bleeding is collected within the abdomen, giving a compartment, and then suddenly bleeds more. So careful, reevaluate, and then remember the big 5s, especially if you're going for the operation theater. And if there's no response, you have to think of these 3 things, because if you're giving a lot of crystalloids, lot of PRBCs, but not giving FFP and platelets, it will cause dilutional coagulopathy, hypothermia, and hypovolemia. Remember all these 3 and the source control. So these are the big 5s that you should remember. External, any bleeding which is happening should be taken care and should be controlled by giving local pressure. Thoracic needs to be evaluated. Hemothorax will be ruled out by using a e-fast or by using an ultrasound lung or chest X-ray, where you need to put an intercostal tube. If a pelvic is suspected, then do a pelvic X-ray, and you have to apply a pelvic binder. Long bones, you require clinical examination because sometimes they can bleed a lot. Compartment can also happen. So traction should be applied. And in abdomen, a lot of bleeding can happen intra-abdominally before the patient actually collapses. So maybe observation and laparotomy. So think of these 5 when the patient is not improving despite your care. So when a pelvic injury happens and the patient's BP is not getting controlled, because pelvic injury means there's a lot of very small vessels which have broken off in the pelvis. And to stop this bleeding, you cannot operate on open. So what do? You take a bed sheet and 2 people actually pull that with their body weights so as to control the bleeding in the pelvis. If you do not have a pelvic binder, this is the Indian jugaad that you can do. And remember, if you are transfusing 50% of the estimated blood volume over 3 hours, it is massive transfusion. So for a child more than 3 months, the estimated blood volume is 70 ml per kg. And if there's so much blood loss, then you have to not only give PRBC, you have to give your FFP and platelets also. And definitely look at the calcium, because hypocalcemia will happen if you give a lot of PRBC, and hypothermia because the blood products are cold. So remember this lethal triad, which can happen if you give large amounts of fluids and blood. Usually a liver and spleen injury would be a conservative management, but if with a liver and spleen, it's unstable, you might open. Very rarely you will open and pack the abdomen. Brain injury would be mostly conservative, but if there is a severe TBI with a midline shift, then you will definitely take the patient to OT. So a tension pneumothorax needs to be drained. You can put tension pneumothorax means the BP is falling. So you need to put a needle in the second intercostal space. A large pneumothorax means the same X-ray, but the BP is stable. So you can put a chest tube in the fourth or fifth intercostal space and mid-axillary line. There's a difference between large pneumothorax and tension. Word tension means the BP has fallen. And if the bleeding in the chest tube is more than 20 ml per kg, then or more than 2 ml per kg per hour, then you might have to open the chest. The surgeon might have to consider opening the chest. So you have to have some endpoints: stable BP, stable oxygen saturation, lactate below 2, normal coagulation, normal temperature, urine good, and no inotrope is the endpoints that we would like to manage. But sometimes the injury is so much and so large that you cannot take the patient to an OT. So you do some damage control. You are not going to do a definitive surgery, but some repair of the trauma which can happen bedside so as to control the bleeding and not repair the trauma. So this is a damage control surgery that you should be aware of, where you are actually not going to repair or do the corrective surgery. So minimum surgery is done to achieve hemostasis, limit contamination, and temporarily stabilize the fracture. The aim is to physiologically restore the hemostasis in the body, and then maybe our next day or day after you return to the OT for the definite surgery. Then there is something called as the damage control resuscitation also. This is also equally important because if you give lot of blood volume and target a near normal BP, then those arteries will continue to bleed and ooze. So sometimes permissive hypotension so that the blood leakage stops is also okay. So you should know about damage control surgery, permissive hypotension, and hemostatic resuscitation. Hemostatic resuscitation means you have to give the FFP and platelets with PRBC. And trauma patients keep a blood pressure just okay. You don't need a high blood pressure. So whenever there's a head injury, you need a high blood pressure so as to maintain the MAP and the CPP. If there's no head injury and there's a penetrating injury or a blunt injury, then just the presence of a radial pulse is sufficient, or a systolic BP of 90 is sufficient, because the more you give a target high BP, the more the blood will leak. And remember, use blood products. Do not be afraid of blood products when there is a hemorrhagic trauma that has taken place. And whenever you give a 1 PRBC, give 1 FFP and 1 platelets if you're thinking the patient is going for a massive transfusion. Trenexa should definitely be considered in all polytrauma, provided there is no blood in the urine. If there's blood in the urine and you give Trenexa, it will cause clots, and then we will have to put a suprapubic cystoscopy. The CT scan should only be done when the patient is stabilized. If you take an unstable patient for a CT scan, it will become the tunnel of deaths. So make sure the patient is stabilized before you shoot for CT. MRI is not at all required in any trauma protocol. It's the CT which is to be done. And if you're in doubt, do a whole body CT. But you should not abuse the whole body CT also, because it is causing a lot of radiation exposure in a child who is at maximum risk of developing radiation-induced carcinogenesis, because maximum growth is taking place at that time. If you have a portable CT, then it's a boon. You can bring the CT to the bedside and do the head CT there at bedside. And remember, the focused assessed sonogram into trauma is very, very good. But it is originally for abdomen, and then it went to even the lung, pleural effusion, hemothorax, pericardial, tamponade. It includes all of this. But it will just tell you that there is a fluid there. It will not tell you whether the fluid is perforation or it is just a transudate or it's a blood. but it will give you that there's a lot of fluid, and it will not tell you in the abdomen where the fluid is leaking from. But it will give you an idea that there is a fluid and it is increasing, that you might need to shift the patient for a CT, angio, and maybe OT also. So the purpose of FAST is to know that there is a bleeding, but not to find out where the bleeding is happening from. You can do these LDH, CPK, lipase, amylase, urine routine, and skeletal survey radiographs, because sometimes in a case of polytrauma, you might miss a fracture of the wrist because you were focused on other bigger fractures and saving the life. So skeletal survey radiographs are usually done in all this. And remember, the fluids that are very important is a crystalloid, and dextrose is usually not given until unless the patient has hypoglycemia, because trauma itself will lead to a lot of hyperglycemia. So give lots of normal saline, and after maybe 6 or 8 hours, you might consider DNS as a fluid. And definitely consider fentanyl for your pain. Don't forget TT. Never a orogastric tube, nasogastric tube. Why? Because if there's a basal of skull fracture, you put the nasogastric, it will go inside the brain. So always a orogastric tube, not a nasogastric tube. And broad spectrum antibiotics depending on the injury. So this is broadly, I'm telling you, the primary survey. You should consider all this ABCD, then go for investigation, decide operative or stabilization, then do a secondary survey, consider whole body CT over here. So after secondary survey comes whole body CT. In the primary survey, you're doing just bedside tests. And then you reevaluate, and then you consider what to do. So this is the brief idea about polytrauma. Now I will shift my lecture to basically traumatic brain injury, because that's an entirely different ballgame. And before I go, I think so Dr. Rajendran has joined. And Dr. Singhavelu sir has also joined. We welcome you, sir.
Thank you, sir. Thank you. Thank you. Good
Welcome
morning
and
to all.
congratulations, sir.
Thank you. Thank you, Ajay ji. Thank you. Thank you.
Sir, good morning and welcome.
Hi,
And
Shyam
many
ji.
congratulations.
Thank you. Thank you. Convey my regards to all.
Sir,
Sure,
from the whole Delhi chapter, sir, we are privileged to have you here. I think so. From the north, will be the first who are having you here after winning your election, sir.
Like for me also, it's first I'm going for the second one. Our own Marina Pedican, where Rajendran is also there. I'm just on the way. I'm very happy, sir, to hear your wonderful lecture. And at the outset, I congratulate each and every one of the Delhi branch under the leadership of our Kog, and our Shyam is there, Ajay is there, Maninder Singh, and all the participants for giving me this wonderful opportunity. And definitely, as a national president-elect, I will do my best with all of you for the betterment of our IAP. Our main aim is unbiased approach to IAP to uplift our, not only our IAPians, and to through that is my always I put my mottos, championing the cause of every IAPian. Why? Once we are all right, when we are in a good position, we can deliver good things to the community. So second, I mean, you all would have seen my manifesto, humble IAPian. I will never change in my behavior and my attitude. My attitude will be towards what I can give to IAP. I need, because you are the headquarters people, you are the people with great academics and with administrative capacities. I need your help and guidance during my career, by which we can uplift IAP in a better way. At the outset, I congratulate our treasurer, our Alok Bhandari, who was from your branch. So for his success also, I thank you all for giving me this wonderful opportunity. We'll be together, we'll work together. Because one more thing I want to add, when I became vice president, the first program I took part is in Delhi. So
No,
the first program, which I cannot forget. So that gave me a very good journey throughout the year. And at that time, the leaders told that, sir, you should become a president. You are in 24 January, you told it has happened in a short. So I should thank all the members of Delhi and Shyam sir, especially Maninder, and all who have helped me, I cannot forget. Thank you, sir. Thank you. I don't understand much before academics. Thank you for giving me this wonderful opportunity. And also thank my president, Rajendran, who is always behind me, encouraging me in all other things. Thank you. Thank you all, sir. Bye.
Thank you for your blessing, sir.
Thank you, sir. Rajendra sir, we have finished the first part of our talk and we are moving on to the second part, that is traumatic brain injury. Before we go on, I'd like to introduce Rajendra sir. Sir is a teacher of teachers in pediatric intensive care. He is a senior professor in pediatrics and PICU. Sir has been the organizing secretary of National Pediatric, which was held in Coimbatore. And presently, he is leading the KMCH Institute of Health Science at Coimbatore. So, with that said, can I move on to the second part of the topic?
Yeah, thank you, Maninder, and for your nice introduction. And really thankful, my friend Maninder. And really wish my Alok Bandari, sir, as treasurer, and Anurag Agarwal. So thank you very much. And please go ahead with our academic program. Thank you very much. I will be here, sir. Please proceed, sir.
Right, sir. Thank
Welcome,
you.
Dr. Rajendran, sir.
Sir, thank you, sir. Thank you, sir. Thank you, sir. Please proceed, sir. Please, sir.
Yes, sir.
Dr. Maninder, one question if I can ask.
Yes, sir. Yes, sir.
You said CT scan in a case of head trauma. Now, when should we get it done? What is the time? 4 hours, 6 hours? How will you take the decision? Parent says कि कब करवाना है? अब करवाएं, कल करवाएं, watch करें 24 hours. What is that protocol?
So I have told you the PCAN score, sir. I'll show you the PCAN score again. So in that scoring, sir, this is a score, sir. So if the child is not thrown a seizure or is fine within 6 hours, very unlikely the child will have any problem after 6 hours. Very unlikely. So there's if there's no depression in sensorium, child is feeding normally, no excessive vomiting, he will not go for he will not require a neurosurgical intervention. So unnecessary doing a CT for documenting injury is not required if you're not going to intervene.
Right.
That's why the PCAN score has come into being. So sometimes we find there are some minor injuries. It creates a lot of trauma to the parents, but it is physiologically not needed because you're not going to intervene.
Right. Thank you.
Yeah, one thing is before going for our next topic and coming to the trauma basics, stabilizing the pediatric polytrauma, that you have to aware that core principles and use the structured primary survey. That's very, very important. And children with common said usually common said very well. Hypotension is a very late and omniscient sign. So always you have to treat tachycardia and poor perfusion and altered mental status as early as possible. And because it's an early sign of shock, and you can resuscitate aggressively, but very safely you have to do it. That initial isotonic crystallite 20 ml per kg may be useful. And in case ongoing hypertension, you have to think of blood product, you have to give PRPC as early as possible. Thank you very much. Thank you.
Right, sir. So moving on to the focus part of TVI. So we have all discussed so TVI is very common because of the bigger head size in children. So most of the injuries happen because of falling from the bed or falling from the bike or somebody hitting from the motor vehicle. So we have already discussed why it is harmful. TVI, there is more risk in the child, not because of only of head injury, but because of airway issues also. And the morbidity is very, very high in case of children. We have already discussed this. These are the secondary injuries that we need to prevent. The hypoxemia, hypotension, hypercarbia, hyperthermia, hyperglycemia, hypoglycemia, hyponatremia, seizures and infection. We should be very, very careful because if you do not control this in the first 1 hour, the patient has a high risk of death in the next 4 or 5 days or maybe after 2 weeks. So TBI is defined as mild, that is between 13 and 15, moderate 9 to 12, and severe 3 to 8, according to the Glasgow Coma Scale. Now, this is a world famous Glasgow Coma scale, which was, it's a very interesting story if you know, that it was made by 3 anesthetists who were sitting in a pub in Glasgow, and they decided that we need to have some scoring, and they jotted this scoring on a tissue paper, and now it's a world famous score, which was later became evidence-based. It was made in a bar sitting on a by the anesthetists because they needed some objective markers. And this is the Glasgow Coma score, which is now being practiced. Now, what I want to highlight is the pediatric one because the verbal response is very different. If the child is consolable, it is a score of 4. If the child continues to be irritable, that is 3. Now, this is the one we should work upon. A persistent irritable child is never a good child. You have to work. And agitated means 2. Work means you have to evaluate that child. So mild TBI, as Dr. Lalit had also told, that sometimes there's a mild injury where there's a normal mental status, no significant loss of consciousness. It's called concussion. Here the child might be a little disoriented, confused, little fatigued. A CT scan here might not be required if the child is okay. But over here in a later part, you can do a MRI. But CT at this acute stage, we are discussing acute stage is not required. So in acute state, CT should be focused whenever you want to do a neurosurgical intervention and you think that something is grossly gone wrong. So this is the escalation pathway you should be aware of. We'll come to that in detail. So keeping it simple, this is a normal brain, 80% by tissue, 10% is by blood, 10% is by CSF. Whenever there's a blood inside, the blood and the CSF comes down so that the brain is preserved. And whenever it increases more, the blood and CSF further goes down so as to preserve the brain. And later on, if the brain gets compressed, the injuries will become more. And because the blood flow is getting low and low, it might again cause more injury. So you have to understand the CSF and the blood, which takes the brunt of the trauma so as to save the brain. And this is the Monro-Calorie principle. So whenever an injury happens, whenever there's inflammation and the swelling happens. And because of this swelling, the blood supply decreases and then the CPP decreases, which further causes ischemia and acute brain swelling further increases. This is a vicious circle which happens because the brain is protected by a skull bone and doesn't allow the pressure to be released outside. And you should know this Cushing's reflex also, which is a protective reflex. So whenever the intracranial pressure rises, there is a decreased blood flow to the brain. Then the body will try to increase the blood pressure so as to increase the MAP. This will cause hypertension. And because suddenly the carotid receptors find there's a BP going up, the parasympathetic stimulation causes bradycardia. So hypertension with bradycardia and respiratory suppression is a dangerous sign in traumatic brain injury or any case of ICP. So we have to maintain the CPP. CPP is arterial blood pressure minus ICP. Now, ICP, we cannot control it if we are not doing a surgery or we have some maneuvers to control the ICP. But BP we can increase so that CPP is maintained. So whenever there is a ICP surge, simultaneously, if you increase the arterial blood pressure, the CPP will be maintained. So do not tolerate hypotension in case of traumatic brain injury. Hypotension in traumatic brain injury is not good. You have to maintain the MAP so as to maintain the cerebral perfusion pressure. Now, a 2.5-year-old child, 10 kg, brought to the hospital convulsing, BP is 80, 120, is a systolic for a 2-year-old, small pupils. The primary concern over here is a high blood pressure, shallow breathing, small pupils. That means there's something definitely going wrong with the brain. So over here, if you see the pat triangle, he's drowsy, breathing is shallow, he's pale, and the BP is on the higher side. So this is how we position ourselves around the patient and work on the patient. So we do a airway maintenance, do the suctioning, do the jaw thrust, cervical spine precautions, give oxygen ventilation. If there is an active bleed that we can see, we try to control it and give fluid simultaneously and do a AVPU score and look at the pupils and the dextrose and then expose the child. This is how you work. And over here, when you find you're given a fluid and child is pale, you arrange for blood. Do not send for group marking. You just send a O negative PRBC and give the blood. That is the take home point today. And also in E comes E fast. So learn these 3 points when you're managing a brain injury patient. So general impression, this was a case of severe TBI, most probably with raised ICP because Cushing's was active, suspected cervical spine, and basically the child is pain. Maybe there's a hidden bleed like in the abdomen. So should we get a CT done quickly in this child? No. You have to stabilize the patient first, secure the airway, prevent the hypoxemia, hypoglycemia, hypovolemia, and then go for CT scan. And intubation, when do you want to do? When the child is not able to breathe properly, not able to maintain the airway, the GCS has fallen over 2, GCS is fallen below 9, and you find that the child is not responding to your fluid boluses. Then you perform an RSI. I had shared in the group what all drugs you should follow in RSI. Spine is never taken care of in India. This is how usually a trauma patient is shifted. This is how ideally he should be shifted to the ICUs. So look, protect the spine if possible. This is the jaw thrust maneuver that I'm talking about. This is the stabilizing the neck. This is the manual inline stabilization that we were talking about. And these are the drugs. You give a IV lignocaine 1 mg per kg, analgesia, fentanyl, sedation. You can use benzodiazepine, etomidate, and if there's hypertension, give propofol, and neuromuscular blocking the rocuronium. After that, you intubate the child. If you are confident in intubation, always have a backup. Avoid succinylcholine. Sometimes there will be hyperkalemia and muscle injuries. Do a focused history. Send somebody how it happened, what was the risk, and any witness that happened. Then you do your emergency management. Intubation, we have already told you about cervical spine. Hypertonic saline should be given whenever you're suspecting ICP. You give 500 kg over 15 minutes, and you do a bag and mask ventilation before intubation because apneic intubation is not done in TBI because hypercarbia will cause cerebral hyperemia. Volume status need to be controlled. You have to maintain the blood pressure at least more than 5th centile for that age. Hypotension should never be tolerated. And after stabilization, you shift for your CT head or spine, and then you call your surgeons what he wants to do because the surgeon also will not operate if the CT is not there. But do not repeatedly repeat CTs after 24 hours. Only if there's a neurological deterioration, then you do a repeat CT scan because hardly in India anybody practices the intracranial pressure monitoring. We have already discussed the spine imaging. Now let us discuss how to interpret a CT. So this is how you learn. You can remember this blood can be very bad. That means you look at the blood inside the brain. You look at the cisterns. You look at the brain. Then you look at the ventricles. Then you look at the bone. We'll go one by one. So you should know many surgeons will be using the term suprasellar. Suprasellar means that is just above sella turcica, that is above the pituitary fossa. Okay, you should know what it means, suprasellar. Then supratentorial means anything above the tentorium cerebelli. That is supratentorial. So above sellar and above tentorium, you should know the difference between them. So here, this is basically, I think supratentorial means includes the cerebral hemispheres. And it includes the cerebrum, the basal ganglia, thalamus, lateral, and fourth ventricles, third ventricle. And here we are talking about basically your hematomas, infarction, whereas suprasellar is more towards craniopharyngioma, optic glioma. You should know about these differences because terminology sometimes can be confusing. And this is, you should know what to look for. So this is corpus callosum. Below that is the lateral ventricle. Then comes the thalamus, then comes the midbrain, then comes the pons, and then comes the medulla. Next to the pons over here, you can see the fourth ventricle, and this is the sella. Above this is the suprasellar. This, hope things are a little bit clearer now. If you look over here, this is the lateral ventricle. This is the third ventricle. And then comes the fourth ventricle, and this is the aqueduct. So the next to the fourth ventricle over here, you can see the suprasellar cistern, or you can see the interpendicular cistern. You should know about this cistern. And you can see around the third ventricle, there's quadrigeminal cistern. So you should know around the third ventricle, what cisterns are there. Around the fourth ventricle, what cisterns are there. Then comes what is a cistern and what's a ventricle. Cistern is basically the fluid which is outside and in between the brain, cushioning the brain. In the subarachnoid space, it's like a cushion. And if these cisterns are compressed, you will know what part of the brain is getting affected. Ventricles is like the plumbing system inside the brain, the third ventricle, fourth ventricle, it is hydrocephalus. It has nothing to do with ICP. ICP means cisterns are getting compressed. Ventricles will also get checked eventually. And sinus venosus is the brain, the CSF gets absorbed into the sinuses and then goes into the IGV. So the CSF flow is from the choroid plexus to the ventricles, to the subarachnoid space, to the arachnoid villi and the sinus venosus. So this is, you should know how an interpendicular cistern looks like, because this is, they will ask you what is how the cisterns. So just giving the two views that you should be aware of. This is the lateral ventricle. This is the third ventricle and this is the fourth ventricle. So if you see, there's an interventricular foramen over here between lateral and the third ventricle, and between the third and the fourth ventricle, there is cerebral aqueduct. This is how the ventricular system looks like from the side, and this is how it looks like from the top. So this will be the lateral horn of the ventricles. This will be the inferior horn. Over here will be the third ventricle. This will be the aqueduct, and this will be the fourth ventricle. So if you imagine a CT over it, so these ventricles you should know, and opposite them will be little cisterns. You should be aware of these cisterns. Where are they placed? So let us go one by one. Let us focus on the blood now. So epidural hematoma is a collection of blood which occurs between the dura and the skull, and it usually does not cross the suture line. And it is usually an arterial bleed. So whenever there's an arterial bleed, you have to take for operation. Epidural hematoma is usually an indication to operate by a neurosurgeon. This is how it looks like a lens which will not cross the suture line usually. The subdural hematoma is between the dura and the arachnoid. It crosses the suture line. It crosses the suture lines also. And it usually happens in old people or those who are having anticoagulants because of the rupture of the veins, the bridging veins. Then this is giving you a idea about the various types of hematoma. This is the epidural, this is subdural, and this is the subarachnoid space. Between the various cisterns, if there is blood, this becomes a subarachnoid hemorrhage. And diffuse axonal means it's like a crack in the whole skull, usually seen in MRI. And intracerebral, there's a bleed in the skull. So if you see this type of picture, then that means a subarachnoid. You see the blood in all the cisterns or subarachnoid space. So if you can just name all of them. So this looks like a epidural. This looks like a subdural. This is intraventricular. This is subarachnoid. This is diffuse cerebral edema. This is intraparenchymal. So epidural means rapid expansion happening because of the artery. Need to treat subdural. If large, you can do a burr hole. And subarachnoid space is usually supportive. But remember, subarachnoid space in a pediatric age group means there might be an AV aneurysm that has broken, and you might need to consider nimodipine. Intracerebral and intraventricular will require a surgical intervention if needed. Then you look at the cisterns. This is very important. Cisterns are the compartments within the brain so as to cushion it. So the cistern that you have to look for is the suprasellar cistern. I remember I told you to look for this cistern. This cistern, if you see, this is the fourth ventricle. This is the pons, and in front of this fourth ventricle here, you will see the suprasellar cistern. Similarly, you will look at the sylvian cistern, which is in the side. This is the fourth ventricle. Then this is the third ventricle we came up, and opposite the third ventricle would be the quadrigeminal cisterns. Well, behind that will be the quadrigeminal. So you should have this. You should know this is the lateral ventricle. This is the third ventricle. This is the quadrigeminal cistern. So once you know where they are placed, you will be able to decipher them clearly. So you have to The cisterns which are of importance are the supracellular cistern, interpendicular, and ambient cistern. These are the basal cisterns. And if they are effaced, that means they are chinked. That means there are signs of raised ICP and maybe even herniation. And Sylvian cistern, if there's a blood over here, that means most likely it's a subarachnoid hemorrhage and a middle cerebral artery aneurysm has broken. So Sylvian cistern is our concern and supracellular interpendicular is our focus. So effaced cisterns means there is erased shape or absence of flattened cisterns means there's an emergency. You have to look for these cisterns and create an emergency and inform the neurosurgical team. Then you examine the brain, look for gray white matter loss, which shows a diffuse axonal injury. If there's a midline shift, and what is the symmetry, and if there is any blood which looks like white, then you know it's a problem. So the midline shift, whenever it is there, you need to inform, and if it is significant, the neurosurgeon will intervene. So then you look at the third, fourth, and the lateral ventricles. This is the late frontal horn of the lateral ventricle. This is the third ventricle. This is the cistern. This is the fourth ventricle. So you should know at what cut what appears. Then you look at the fractures, better seen in the bone window. And then you can do a CT evaluation also, scoring. And these are the various herniations of this. The most important is a hernal uncle herniation, where ipsilateral unequal pupils will be there. So if this is there, that means the tentorium has little bit gone inside. This is a downward herniation which is happening. So focus on the baseline therapies, first line therapies, and secondary therapies. I'll go very fast. Baseline means you have to consider appropriate analgesia, maintain the normal temperature, but no fever to be tolerated, no fever at all. Target normoxemia, normocarbia. Now, this is the famous graph that you will see in all TBI lectures. This is the CO2, this is the PO2, this is the cerebral blood flow. So let us focus on the PO2. When the PO2 falls below 50, you will see the cerebral hyperemia takes place, which is not a good sign. So you do not want to tolerate hypoxemia. Whereas if it goes above 50, there is no greater advantage of a PO2 of 125. So normoxemia is the target. Now let us focus on CO2. Now CO2, when is at 40, it's okay. When it goes above 40, it causes hyperemia, which is not good. And if it goes below 25, it causes cerebral ischemia, which is not good. So normocarbia and normoxemia is the rule. So target PCO2 35 to 40. Less than 30 is also bad. More than 45 is also bad. Less than 30 will cause cerebral ischemia. More than 45 will cause cerebral hyperemia. So transient hyperventilation is good, but not extended. Because if you do extended hyperventilation, it will cause cerebral ischemia and a secondary brain injury will again happen. So keep the head in neutral position if the child is not in shock. Elevate the head, it decreases ICP. Anti-epileptic drug, we only recommend to prevent early post-traumatic seizure so as to prevent the metabolic demand of the brain and to create electrochemical stability in the brain. Levetiracetam or phenytoin, no role of valproate, and no role of late post-traumatic seizure prophylaxis. So you start in those patients who have got penetrating head injury, severe TBI, intubated TBI, or there's a midline shift, or there's a clinically seizure which is seen, and you stop the anti-epileptic after 7 days. But if you feel that the patient has a residual epilepsy, then you will consider continuing those anti-epileptics as a part of late prophylaxis. TT, I've already told, normoglycemia should be maintained. Target a sodium around 145 to 155 as a osmolar therapy. Hemoglobin target around 7. If there is lot of bleeding, maybe 9, but not above 10. Coagulopathy to be corrected if the patient is going for surgery. Corticosteroids have no role. In spite, they have shown to increase mortality. There is no role of steroids at all. So do not give. And whenever you find the pupils have become unequal, give a rapid bolus of 3% saline. We prefer 3% over mannitol because mannitol can sometimes leak from the capillary space and go inside the hematoma And if it is connected inside the hematoma, it will collect more fluid inside the cerebral hematoma. So usually we prefer 3%. Mannitol is though not contraindicated. And elevate the head end if the patient is not in shock, and target a CO2 around 30. So this is the first line therapy we have already discussed. Give a 3% saline bolus. Mannitol is an alternative. Maintain euvolemia, correct hypercarbia. Maintain the blood pressure, and despite that, if it is not getting controlled, intubate the patient, start midazolam at high dose, maybe at 10 microgram per kg per minute, and then moderate hypothermia around 32 to 33. Hyperventilation can go for a longer time, higher serum sodium, and maybe consider a decompressive cranectomy. ICV monitoring is more of a theoretical topic, though in quaternary care centers like ours, we do sometimes do it. And this is how ICP waveform should looks like. This is the normal one. And over here, if the P2 becomes more than P1, that means there's a lot of ICP surge which is happening. Again, NERS is non-invasive method of monitoring brain saturation, easy to apply and easy to interpret. Now we can see the left hemisphere is getting 42, right is getting 55. This is bad. If both are on the same track, 60 and 60, that means it is on the good side. And if you are intubating a patient, paralyze, sedate, analgesia, but do a EEG because there might be non-convulsive status epilepticus happening. And we rely on TCD for even diagnosing brain deaths, and do ONSD regularly in these patients so as to diagnose ICP. So we follow these pillars of neuroconscious PICU. We just do not look at the pupils to decide our management. And these are the BTS guidelines that we follow to the book. And we carry out regular in situ simulations so that we are well prepared whenever there is an emergency. Thank you. Now, I would take some question and answers, Dr. Anand and Rajendra sir, I'll ask you. So the question is, they're asking if there is a normal and active child with a subacute hematoma in the parietal and occipital region, and the child is otherwise fine, is imaging necessary? Over to you, Anand.
Yeah.
So
Can
child
you
is
repeat
fine.
the question?
The questions are there in the chat, but you will not be able to see. It's in a Q&A session.
Okay.
So would you do a CT in this child who's neurologically okay, normal and active, but there's a bulge over here which is seen after a fall from a bed? Hematoma
Should
in the
follow the protocols. That's a subcutaneous bleed doesn't warrant that a CT brain should be done. And if you follow the guidelines given by you and the PCAN basically scoring, then there is no indication for CT in this case.
Correct. Agreed. Agreed in totality. So subcutaneous hematoma is more a cosmetic thing, and which should not evaluate it. Agreed. But if the child is persistently crying, if the child is having repeated episodes of vomiting, then that might not be a subcutaneous hematoma. So the question was very specific. We gave a very specific answer. So sometimes in polytrauma patients, their hands and legs have a lot of swelling, and it's difficult to find IV cannulation site. How do you want to approach this in ER versus in ICU, Dr. Anand?
Yeah. So if there is a lot of swelling and IV access is important, we never wait for an emergency like shock. We immediately find intraosseous line. You should be trained enough to have an intraosseous line. And if you have not done 2 courses like PALS, BPIC, and learn the method of introducing the intraosseous needle, that's the basic thing. I think so. Most of the pediatrician should be able to do intraosseous in this case.
Correct. And in the PICU, we have our ultrasound. It's a controlled environment. Yeah. We can put central lines in a controlled environment. Yeah. So both the answers done.
That's going to take time, but even in the ER, we can quickly do our intraosseous.
So somebody is asking, Can orogastric tube be put in infancy? Will it not cause emesis?
So that's pretty safe. May not be relevant to this topic right now, but orogastric tube to cause basically nausea, vomiting, that's not very common. So it's not going to have lot of gag. Uh, Obviously, we are putting in a child who require inserting an orogastric tube. Here, related to head injury, special precaution is to know that there can be a basilar fracture, and if you are using nasogastric tube blindly, it can herniate into the brain. So that's a special precaution. Otherwise, using a nasogastric or orogastric doesn't matter.
Okay. So we are discussing putting a orogastric tube in a patient who is usually intubated, ventilated, having a severe TBI. We do not want to irritate a mild TBI child with a orogastric tube.
Perfect.
So next question is, toddler develops 3 to 4 vomitings after fall from a cradle within 3 to 4 hours. Rest, he is totally normal. No other problem. So 3 vomitings after a fall. After 3 hours, he comes to you. He is totally normal. Does it require a CT brain?
Yeah, again, you follow the pecan guidelines where they say that's a toddler more than 4 vomitings or 5 or more vomitings. That's a gray zone where you can consider either it's an isolated vomiting, nothing else. Then observe this child for 6 hours, or you can go with the CT brain. That's both are equally okay. 3 vomiting in a normal child within 6 hours of an injury. There, if the method of injury is bad, like the child has fallen more than 3 meters height, then probably yes, I will go ahead.
Right. So I'll give a very simple example. So vomiting immediately post fall is because of crying and pain. So that vomiting should not be taken into consideration. If it's a consolable patient and he has come after 4 hours, he has a feed and is okay, maybe not required a CT. But again, risk factor is a fall from 3 hours. And also they have mentioned criteria to do CT scan is parental request. If the parent requests for a CT scan, you do it. You can do it. So choice of sedation, analgesia, and paralysis in traumatic brain injury on ventilator, Dr. Anand.
Yeah. So that's again a clear-cut guidelines. Depends whether it's a shock patient or not. The patient is not in shock. Pre-medicating them with an IV lignocaine is what we prefer. Then choice of sedation can be a midazolam or propofol or etomidate. But if the child is hypotensive, we can go ahead with the ketamine use as well. And we can club it with an opioid like a fentanyl or morphine. And short-acting paralyzing agents like vecuronium, that's rocuronium or vecuronium. For RSI we use, we must avoid succinylcholine as you have already said.
Okay. So one more is asking, if a GCS is low and we have given sedation analgesia for intubation, then how are we going to assess GCS in an intubated patient because of TBI, or it is happening because of sedation?
So that's a continuous monitoring. There are a lot of ways to assess that. Once we have intubated a child, the vocal, the response is not, verbal response is not going to be there. So it's predominantly the higher functions that we are going to assess. And in an intubated child, if the sensory is improving, then person can even pull off the 82. So there are ways where we can assess the level of sedation. There are scoring systems when the patient is on sedation, and you can assess whether how awake is the patient and whether GCS is improving or not. Obviously, the type of sedation that you are giving to this person is usually a short-acting sedation, unless and until they require prolonged, controlled, continuous infusion in the initial part of management of TBI.
Correct. So we follow a protocol called as analgo sedation, where analgesia is more than sedation.
Yes.
And we follow the Ramsey score so as to keep a moderate sedation. So the patient is having like a is not fully awake, but is not having pain. And then we can assess. But if you have knocked out the patient, like you have paralyzed the patient, sedated, then you can do a EG to know for non-convulsive status. That is one way. Dr. Rajendra sir, they're asking in peripheral centers, they don't have MRI machines. So how do we measure ICP? So you are muted, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, we can go for so Cushing's triad now. Usually you can go for usually baseline. You can go for clinical assessment is always better to use it. And some centers, only peripheral centers, we are having a complete ICP monitoring. I think a periodical that conscious level monitoring, and another one is people size assessment. These things we can go it, and if can go for a quick assessment with CT means we can use it easily. CT scan also we can use it. But what we are saying is, and as you said, the heart rate monitoring, sensory monitoring, these things we can do it. But complete monitoring is very difficult. Now that I go for yes, theoretically we can't go for complete monitoring in peripheral centers.
Agreed, sir. So nowadays ultrasound has come, like optic nerve sheet diameter and transcranial diameter. Is it doable in peripheral centers?
It's not no, because sonologist will be there. It's very difficult to go for that. They have to equip, no? They have to know that practically they are not knowledgeable, not that much knowledgeable to go for that ultrasound measuring of that
Optic nerve
circulation
sheet.
speed. Yeah.
So if the people are trained or they're interested in training, they can join these focus courses and learn about it. Though it has a learning curve, the learning curve is small. So the normal range of near infrared spectroscopy is whatever you apply, you see the right and the left, try to keep it above 50. And if it is go above 60, it's okay. But above 80, if it goes, or 90, it means the brain is not functioning. It's just oxygen which is going. So be very careful with nerves also, and see the difference between right and left. One side will be affected or not. Then they're asking uh, uh, regarding steroids, Anand, should we give steroids for ICP?
Well, for a traumatic raised ICP, there's no role of steroids. You have already mentioned in your lecture, and there are specific indications for that. And we are using steroids, like for the spine trauma, there is definite indication within first 48 hours, cervical spine injury, and there are limited indications for steroids here.
Regarding Maninder, regarding going for a spinal injury, and we are using methyl prednisolone, sometimes stem cell therapy, also these things. What's your experience using the stem cell therapy and in spinal cord injuries?
So in acute spinal cord injuries, we are only using high dose steroids, methylprednisolone, though the recent evidence and the recent guidelines actually say it has no mortality benefit and no morbidity benefit. But we are still using it so as to decrease the spinal cord edema. Regarding stem cell in acute spinal cord injury, I have zero experience, never used. Okay, so the take-home message is no role of steroids at all in traumatic brain injury for whatever indication. Only steroid that you can give in a polytrauma patient, maybe for a catecholamine refractory shock, you might consider if there's an open wound with signs of secondary sepsis. Otherwise, no role at all. So post head trauma, if there is a nasal bleeding present and the child is totally normal otherwise, is CT indicated, and should we give an antibiotic? Anand.
Yeah, I've not got this question.
So patient has a head injury and he's having nasal bleed. So nosebleed. So basically, I'll answer it. So whenever there is a nasal bleed, it's a high risk injury area. It's a sensitive area. It can be bleeding due to the picking of the nose also. But if the bleeding is persistent, you have to go for a CT PNS. You have to look for the bleeding parameters here. inside if there's a nasal bone structural fracture which has happened. So that time you can do it. And because this is a very contaminated area, if you are going for OT, then the antibiotic is definitely indicated.
Yeah, definitely we can go for cephalosporins. I
face down.
think the third generation cephalosporin we can give it as usually. So they definitely indicated only what you are telling is correct. Yeah.
So
Dr.
dose
Maninder,
of
many
steroid.
times the children fall face down and they hit the nose. There can be some local injury can be seen.
Correct, sir. So again, if it is a persistent nasal bleed, then only we'll go for it. For local injury, we do not want to go for it. But usually they go to a ENT surgeon, he advises a CT PNS, and he wants to look for a fracture inside.
And you can go for that T-back, no? So we can go for that also local applications also we can do it to preventing that nasal carriage so spread on also. And that also you can do it, local application also.
Yes, sir. So people are asking whole blood versus PRBC. What is recommended in massive transfusion? Anand.
Yeah, so it's a component therapy only. And what we can do if there's a massive transfusion or expected massive transfusion, that means within 3 hours you expect to give more than 50% of the blood volume, or by 24 hours you are replacing more than one complete blood volume, then the ratio of 1:1:1 has to be maintained. One packed cell to one plasma to one platelet, that is required to prevent coagulopathy. So whole blood, I am not very sure if it's
Whole
easily
blood is
available in the blood
practically
bank.
obsolete in India.
Yes, it's obsolete.
You do not get whole blood in India.
Yeah, that's what I said, that I doubt if it is available. Yeah, you need to request it.
You need to request and they'll reconstitute
Yeah,
with PRBC, FFP, and
yeah,
then
right.
give it to you. But as such, whole blood is not available as per blood bank guidelines.
Yes.
So, Rajendra sir, they're asking when to avoid mannitol in TBI.
So mannitol, if you are going for any EDH, no, definitely it may aggravate. So that's a very, very important thing. So usually, as much as possible, avoid mannitol in brain injuries. Unless having total edema, you can use it. But if you are having any collection anywhere, any subdural, extradural, better to avoid, you can go for 3% sodium chloride is a good alternative. So I think better to avoid mannitol.
So the one more question is minor injuries which happen. Can a pediatrician apply stitches or should we refer to pediatric surgeon, Dr. Rajendran?
So I think we can again see where they're coming. For minor injuries, if you're having brain is okay, otherwise if you feel everything okay, so you need not refer another child for 90 kilometer, 100 kilometer for suturing. If the pediatrician is well versed with that suturing, and if you're taking precaution with aseptic precautions, definitely they can do suturing if they are well versed. Because as a MBBS, no, medical legally, you can do it suturing, definitely.
My only, sir,
Dr. Maninder, but sometimes if it's a cosmetic purpose, like
I agree, sir.
cut
My
it
only
on the
2
face
cents
or
would be,
somewhere.
if there's a facial injury, a plastic surgeon would be better. If it's a facial injury,
Yes.
other than face, I think so pediatrician can suture.
Yeah, definitely you can do it. Now, a stapler available, now they can do it there. So, facial injury, as you said, now you can go for a plastic surgeon.
So there, Rajendra sir, they're asking, can we give 3% through a peripheral line or do you require a central line for giving 3%?
So, better you can go for central line is better always. And if you are having otherwise, you can go for 3% sodium chloride. Time being, you can give it.
So we can give it through peripheral line. There is no contraindication. We can definitely give it. We don't want to wait for a central line.
Yeah.
But if there is a central line, I would prefer to give it through a central line.
Yes, perfect.
Yes.
Now, this question was the first question, so I'll ask Dr. Anand. So a child who has ever trauma and has a bone in the iron rod in the head, has a SDH mild, his GCS after 48 hours is still low, but having spontaneously breathing. The GCS is less than 8. What should I do?
Well, it's a very complex situation. A multidisciplinary approach is required. First thing is to stabilize the patient. The airway, breathing, circulation matters.
No, after 48 hours.
Yeah,
They have
after
intubated
48
after
hours.
48 hours till the GCS is low.
Yeah, and the Rod is there in the brain.
He got rod removed, everything done.
Okay. And
Child is
what's the
still
situation?
TCS 8, no inotropes, nothing.
Yeah. So just wait and watch. And this is subdural hematoma, you are saying.
It's a sub SDA. Maybe they can go for a tracheostomy. Early tracheostomy will remove the part of it. So early tracheostomy would be the right thing.
Yeah.
This was a big question. I just gave you the snippets of it. I so I think so. We have
So
answered
basically,
majority.
continued care is required. So multidisciplinary approach, continued care. Keep on reevaluating the patient. How is he progressing? Involve other disciplines like a neurosurgeon and reassess. And if it's required to have a airway because of the low GCS, yes, tracheostomy, early tracheostomy should be preferred.
Correct. I think so. I have answered everything now. Before I close, I'll take few words of wisdom from Rajendran Sir about polytrauma and
Sir, I take this
medical.
opportunity to congratulate Dr. Rajendran for being elected the EP member of Central IP from Tamil Nadu for the year
Congrats, sir.
2026.
Yeah,
Congratulations, sir.
thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir.
And thank you, Dr. Maninder, for a wonderful presentation.
Thank you, sir. Thank you. Any closing remarks, Rajendra Sir, and pearls of wisdom?
Yeah, so we have to be coming to that traumatic brain injury. So you have to always careful that these children are different from adult because of their skull is thinner, and another one is brain has higher water content than that, and less myelination also, and so usually the children's neck muscles are weak and more acceleration and deceleration injury also, and they can maintain normal BP until late. So don't keep that BP is one of the sole criteria. And child may go for silent hyperperfusion. So don't believe the BP. That's a very, very, very important thing. And so two important thing is another one is primary brain injury. Usually if you're going for example contusion, laceration, all those things, no, usually it may not reversible, but that secondary brain injury is a very, very important thing. It occurs after the initial impact due to hypoxia, hypotension, and raised ICP, seizures, and another thing is either electrolytes imbalance and thermal irregularity also, infection also. These are totally preventable and treatable. So you have to, our focus should be of more of acute management, and always you have to further you have to avoid damage. That's a very, very important take-home message I want to tell regarding TPI. Thank you, sir. Thank you.
Thank you, sir. We welcome Dr. Bennett, sir.
Thank you, sir. It was a wonderful discussion to hear, especially the talk by Dr. Maninder and followed by discussion with the Dr. Anand and with contribution from Dr. Rajendran. So thank you very much for the wonderful discussion, and it was a good learning for me. Actually, I am joining always because of for my learning, not for any other thing. It's a wonderful occasion. Thank you very
Dr.
much. Sir.
Maninder.
Thank you. Thank you.
Thank you, Dr. Anand, sir, for wonderful comments.
Dr. Maninder, one simple thing I want to know. Dr. Maninder, can I ask one simple thing? Very nice presentation. What is the simple equipment to measure ICP? Otherwise, or it is always we measure clinically?
Sir, if you want to see clinically, then pupils, heart rate, and blood pressure. If you want to measure it, then maybe optic nerve sheet diameter and ONSD. If you want to go for correct measurement, then invasive through ICP monitoring.
So you have a particular monitor for that, it's a kind of a
Sir, we have ICP monitors, sir. So we can put it in the ventricle, we can put it in the brain parenchyma or subdural or subarachnoid bolts.
So these are being routinely used in
in quaternary care centers, not even in tertiary care centers.
Okay. Otherwise, so majority of the time the assessment is clinically, right?
Majority of the time would be clinical and optic nerve sheet diameter.
Thank you. Thank you.
Yes, sir. Maninder is said, easy thing is as if you are trained, even periphery also, optic nerve sheath diameter monitoring is the ideal thing. And another thing is non-invasive. And even register also, they can monitor easily, sir. Easy thing, sir. But you have to train the people. That's very important thing.
Thank you, sir. Thank you.
It's a bedside test.
Yeah.
Okay, the final comment from Dr.
Thank all the
Anand, sir.
delegates also.
Yeah. Yeah, so my comments, wonderful presentation. It's very difficult topic to cover in less than an hour. Maninder can justify this. Always important message whenever you are managing polytrauma. Know your protocol, be aware of the situation, be calm. Someone should be leading the team who knows the protocol well. Use all your resources, audiovisual aids. Don't delay resuscitating with the blood products. If it is required, you are looking at the hemorrhages. Then, important to prevent secondary injury if there is a traumatic brain injury. Take care of your spine as you are taking care of your brain and other body parts. Use personal protective equipments. You save yourself as well. Use fast protocol and communicate with the family, document. And important thing that we always miss even in the tertiary care center, take blood sugar as well as the blood group. Someone should be sending samples for blood group and cross match. Thank you.
Perfect, perfect. Bilkul,
Thank
to
you.
the point, very clear experience oozes from Anand. Now,
Meena, are you there?
Yeah, thank you, Dr. Maninder. And it's almost, I know, 10, 15 years, Dr. Maninder is always very entertaining and as well as very jubilant person. And always, wherever that Maninder is there, no, a lot of 10 or 20 persons will be there for his entertainment joke also. And on behalf of IAP Tamil Nadu and Pondicherry chapter, I welcome all the persons and from Delhi to come to 2027 National Pedicon at Coimbatore. So I am the organizing secretary. So I think you can have definitely good time at Coimbatore, and I welcome one and all. Thank you. Thank you.
so we'll take final closing remarks from Dr. Meena.
Thank you, Dr. Maninder, for wonderful, concise talk. Definitely, polytrauma, one of the life-saving incident that need the holistic, structured, and proper way approach. As Dr. Anand rightly said, we should properly manage the child along with proper maintenance of the documentation, because that might be create a lot of the problem in the medical legal aspect. But in even in the private setup, if you want to send the child to in the higher center, I would like to say first try to stabilize the child and just inform to law enforcement agencies if the accidental is case, then refer to higher center. Thank you, and thank you, Dr. Rajendran and Dr. Anand, to join our this scientific activities. And after long time, Dr. Bennett, I would like to thanks to you. We get the opportunity to see your face in on this activity again, because Dr. Bennett is regular participant as well as discussion for the all IEP daily academic activities. Thank you. Thank you, dear.
Thank you.
Dr.
Thank you.
Bennett is it's an important person in Kerala. That's a
No,
very VIP. Okay.
thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Bye,
Thank you.
everyone. Thank you.
Thank you very much.